We're here to have a panel discussion about health and wellness in primary care. And UTT has joined with Caribbean medical providers abroad to host a conference this weekend on this topic. But where did this concept of primary health care originate? Primary health care as a concept was originally launched in 1978 at World Health Organization conference in Alma Ata in the former Soviet Union, at which some 150 governments were represented. The Alma Ata Declaration of 1978 emerged as a major milestone of the 20th century in the field of public health, and it identified primary health care as a key to the attainment of the goal of health for all by the year 2000. Primary health care fulfills the role as a gatekeeper of the country's health system, and its central function and main focus is the overall social and economic development of the community. It is the first level of contact of individuals, the family and community with the national health system, bringing health care as close as possible to where people live and work, and constitutes the first elements of a continuing healthcare process. It tackles the main problems in the community, providing appropriate promotion, preventative, curative, and rehabilitative services by involving all related sectors and aspects of national and community development. It requires maximum community and individual self-reliance and participation in the planning and organization, operation and control. 36 years from its conceptualization, Trinidad and Tobago has developed a network of 97 health centers, 9 district health facilities, and 9 public hospitals. National data shows that this country is in an epidemiological transition with a decline in communicable diseases accompanied by an increase in chronic non-communicable diseases, which contributes to 60% of all deaths. CNCDs are similar in that they are linked by a common set of modifiable biological and behavioral risk factors, primarily obesity, high cholesterol and high blood sugar, high blood pressure, unhealthy diet, physical inactivity, tobacco consumption, and alcohol abuse. Given the core function of primary health care, why is this occurring? And has primary health care in Trinidad effectively dealt with its core mission of promoting health, wellness, and prevention of disease in Trinidad and Tobago? Join us as we discuss health and wellness in primary care, the current state of the healthcare system in Trinidad and Tobago, and ways of improvement. To start this evening's proceedings, it is my pleasure to introduce to you Dr. Fazal Ali, Provost of UTT, to open this evening.
Mr. Kwesi Mutima, the Deputy Chairman of the Board of Governors of the University of Trinidad and Tobago. Mrs. Karen Ram Sahani, Member of the Board of Governors of the University of Trinidad and Tobago. Professor Diana Ryan Singh, the President of the University of Trinidad and Tobago. Dr. Gerard Antwine, Founder of Caribbean Medical Providers Practicing Abroad. Esteemed presenters, Dr. Philip St. Louis, Dr. Carol Ann Barrett, Amelia Warner, BSN RN, Dr. Leanne Conyet, Dr. Stacy Shamali, Dr. Agatha Carrington, Program Administrator, Masters in Health Administration at the University of Trinidad and Tobago, Madam Chairperson, Ms. Dean Sami, graduate of UTT's Masters in Health Administration Program, Moderator, Dr. David Santana, finally a student of the Masters in Health Administration Program at the University of Trinidad and Tobago, specially invited guests, ladies and gentlemen, good evening. Good evening. I am happy to be here at today's panel discussion to bring greetings on behalf of the governors of the University of Trinidad and Tobago. This is a collaboration that UTT, as a national university, is proud to be part of, as it directly redounds to the benefit of our nation's citizens. I would like to take this opportunity to recognize the commendable initiative taken by those at the Caribbean Medical Providers Practicing Abroad, as well as its founder, Dr. Gerard Antwine. We are grateful for the positive and important work that the CMPPA is doing and will continue to do. Indeed, healthcare is an increasing concern in Trinidad and Tobago, with obesity on the rise and with it an alarming high incidence of lifestyle diseases. We know that this conference is a timely one. Yet, it is not only a local problem. Researchers at the U.S. Center for Disease Control and Prevention analyzed hospital data on up to 8 million patients yearly for the period 1995 to 2008. The results of the study indicate that stroke rates in 5 to 44-year-olds rose by about a third in under 10 years. The researchers looked at figures for strokes due to blood clots and those caused by bleeding on the brain. The rate of strokes from blood clots increased by 31% in 5 to 14-year-olds, from 3.2 strokes per 10,000 hospital cases to 4.2 per 10,000. These were increases of 30% for people aged. There were increases of 30% for people aged 15 to 34 and 37% in patients between the ages of 35 and 44. Ladies and gentlemen, this is clearly not an issue that is related to the elderly alone. High blood pressure, diabetes, and obesity are often found to be common among stroke patients, but all of these can be prevented, alleviated, or controlled in some way. Just as important is the need for education and awareness. Many persons, for instance, are unaware that a stroke patient suffers from confusion or may have trouble speaking. Also, many do not know that a stroke can go undiagnosed since the symptoms are not painful. According to the neurologist Dr. Shirish Hastak, a stroke hits a patient like a bolt out of the blue. First, there could be mild slurring of speech or weakness in the hands and legs. This tends to get better within 15 minutes, after which the patient may sweep the problem under the carpet and get on with life. 20% of patients that suffer from mild symptoms go on to develop a full-fledged stroke in the next 48 hours. Also, as many as 60% of such patients miss initial symptoms like numbness or slurring of speech. If they are not treated within a window period of 2 to 4 hours, they can go on to develop disabilities like paralysis and loss of speech. Fortunately, symposia such as these raise awareness and highlight best practices with respect to prevention, treatment, and rehabilitation of stroke patients. I'm glad to see topics under discussion today which include rehabilitation management of the stroke patient and health, wellness, and disease prevention. UTT's own Dr. Agatha Carrington of the Masters in Health Administration program will also be conducting a session on pursuing health and wellness in primary care, a diabetes self-care study in South Trinidad. Ladies and gentlemen, today's session will not only shed light on the problems, but thankfully will highlight significant solutions which can be incorporated into our daily lives. The vision of the Caribbean medical providers practicing abroad is to provide a vehicle for medical and non-medical professionals from the Caribbean to give back to the communities from where their parents or they originated. I again commend them for the excellent work being done and to improve and provide health care to the people of the Caribbean and for creating this unique opportunity for international medical providers to influence the national discussion on wellness. Like you, I look forward to hearing more on this important subject from this evening's esteemed presenters. Thank you, ladies and gentlemen.
This evening's moderator is Mr. David Santana. And when I called Mr. Santana, I said, David, I need you by your sketch. He says, well, Dean, I'm an orthopedic surgeon. So he says, well, I said, David, I need more than that. He said, well, I'm a curiosity old boy. Typical David. So he sent me his bio sketch. Mr. David Santana is an orthopedic surgeon and diving medicine specialist with 20 years' experience in these specialties. He has a Bachelor of Science degree in Chemistry and Zoology from the University of the West Indies, St. Augustine, Trinidad, a Bachelor of Medicine and Surgery from the University of the West Indies, Mona, Jamaica, and is a Fellow of the Royal College of Surgeons of Edinburgh, Scotland. In 2008, he founded the Department of Orthopedics at the Sangre Grande Hospital, Trinidad and Tobago, where he currently serves as the head of the Department of Orthopedics. He's particularly interested in arthroscopic shoulder surgery and has recently renewed his lifelong interest in cosmetic surgery. He's a final year student in the Masters in Health Administration program at the University of Trinidad and Tobago, and a freshman doctoral student in Health Administration at Central Michigan University, USA. Esteemed audience, I hand you over to the capable hands of Mr. David Santana.
Thank you very much. We are going to be very stressed for time, so all protocols are observed. I'd just like to introduce our panel. To my immediate left, we have Dr. Carol Ann Barrett. She was born in Arima, but she left at a tender age of 7. She was brought up in Lawrence Park, Arima. She graduated with a Bachelor of Arts in Spanish and Biology from Washington University in St. Louis, Missouri. And she later graduated from the State University of New York at Stony Brook with a Doctor of Medicine degree. Next to her is Ms. Amelia Warner. She was born in Siparia Road, that is between Siparia and Faizabad. She left Trinidad at age 11 and went to the UK, and at the present time she is a nurse manager of the Stroke Recovery and Rehabilitation Program at MedStar National Rehabilitation Hospital, Washington, D.C. She has more than 20 years' experience as a registered nurse. Further to the left is Dr. Leanne Corniet. She was born in San Fernando, and together with the person immediately next to her, they both went to St. Joseph Convent, San Fernando, of which they are proud. Dr. Leanne Corniet obtained her Bachelor of Science honors from the Faculty of Natural Sciences, the University of the West Indies, St. Augustine. She completed her MBBS degree from the Faculty of Medical Sciences, UWI St. Augustine, and she's now currently serving as president of the Trinidad and Tobago Medical Association. Dr. Stacy Chamley holds a Bachelor of Arts degree in chemistry. She is also MBBS, and she has a master's in family medicine and a diploma in palliative medicine. She is the secretary and the continuing medical education coordinator of Trinidad and Tobago Medical Association. She is a medical graduate of the University of the West Indies in Cardiff in UK. Dr. Philip St. Louis is a board-certified neurosurgeon and also a fellow of the American College of Surgeons. So with this esteemed panel, much of the success of this discussion this evening really depends upon you, the audience. It is an open panel, open discussion, and we are inviting you now to present your questions to the panel. Remember what the topic is. The topic is health and wellness in primary care, with particular reference to the non-communicable diseases such as diabetes, hypertension, and others. Can I have the first question, please? Oh, I know what has happened. You were expecting the panel to talk first. Yes, but that's not the forum this evening. We're inviting you to begin the discussion. Could we, is there a mic? Yes, sorry. There's a mic in the corridor there. Could you just address the panel through the mic, please? As Ms. Sammy said,
Is it on now? Yeah.
yes, go ahead, please.
I was asking how much emphasis is being placed on patient education beyond the hospital. In this environment, are you, through some form, trying to educate the people, the community, as to stroke awareness and awareness of diabetes? Because I know how our diet is as far as it relates to diabetes. Stroke awareness especially, though. I would like to know how much emphasis is being placed on patient education.
Dear Dr. Cornett.
Okay, good evening, everyone. The question is the emphasis placed on stroke awareness, in particular in Trinidad and Tobago. And basically, as part of the United Nations Millennium Goals, looking at this rising epidemic of non-communicable diseases throughout the world, our Ministry of Health, in collaboration with CAREC, which is our Caribbean Epidemiology Center, University of the West Indies, PAHO, WHO, and the Central Statistical Office, they all came together in 2011 and decided to have this nationwide survey called STEPS. And based on this STEPS survey, they came up with all the risk factors associated with these non-communicable diseases. So since then, at the local health centers, as well as in the general hospital, which is where I work, patient education is an important part of management. And as part of the Trinidad and Tobago Medical Association, of which I'm the president, Stacey is the secretary, what we do is that we go out into the communities and we have health fairs. So for example, and we try to go out in the rural areas. So for example, last week Sunday, we had a health fair in Princestown. About a month before that, we had a health fair in Moruga. So we try to go into the community, into the rural communities, and talk about all non-communicable diseases. Because you think about these non-communicable diseases, that they are preventable diseases.
Ms. Warner.
Hi, this is Amelia Warner. I'm a rehab nurse. At our rehab hospital, we do a lot of education on stroke prevention. We have educators that teach patients on their blood pressure, make sure their blood pressure is controlled. So we have blood pressure classes, at least 6 classes during your stay at the National Rehab. With our diabetic patients, we also have diabetic classes that the patients have to attend. It's not a choice. As long as you're diabetic, you have to attend. Each patient is also given a machine and their strips, and they have to monitor their blood sugar. So it's very, very important that you keep a record of your blood sugar. So when you go to your doctor, you can show him the record of your keeping of your blood sugar, whether it's high or it's low. We also encourage the patient to make sure that they get an A1C, which is the 3 months, how your blood sugar is running within the 3 months, whether it's high or it's low or it's normal. So that's very important.
For the members of the public, the A1C test is probably one of the most sensitive tests available for detecting whether your blood sugar has been under control. And if you haven't heard of that test before, I would encourage you to ask your physician, whoever is looking after your diabetes, to run that test on you. It's amazing. I was looking at a study, and I think Dr. Carrington will talk about that tomorrow, where a significant number of people in that study had not heard, we're talking about Trinidad and Tobago, had not heard about the HbA1c test. Those who had heard of it did not know what it was. Those who, and there's also another group which had heard about it, knew what it was, but didn't know what their level was. So we need to educate the public about that particular test, because that is probably, as I said before, one of the most sensitive tests to determine whether your blood sugar has been controlled over the last 3 months, rather than simply a fasting blood sugar or a random blood sugar for that matter. Any further questions, please? Mr. Paul Taylor.
Good afternoon. Good afternoon to everyone. Good afternoon to everyone. I want to follow up on the question in terms of behavior. You mentioned, Doctor, that the survey was done to assess the factors. I'm wondering whether the Ministry of Health or any other agency has identified the persons, the individuals, the institutions that most impact behavior in this country, and really identify those, to work with those agencies to disseminate information about health. Because I think that's really important. The Ministry of Health, as professionals, you go out, but there are people and agencies, institutions that really impact people's behavior, and I think they need to be the conduits to which we also use to send information.
Thank you. I just have a big mouth, so I'm just going to go for it until we figure this out. Thank you. That is a good question. I will tell you what is happening now from a ministry point of view, from what we can see. And I'm a primary care physician, and I work in San Fernando, the heart of the city, so I see grassroots people all the time. The ministry has been pushing through the media, which is probably where a lot of us learn about healthcare issues. Know your numbers. I'm sure all of you all have heard that slogan, know your numbers, and then there was the Fight the Fat campaign that lost a little bit of momentum. It started off really well. I know for a fact, and I can speak for Southwest Regional Health Authority because that's where we're both from, but Southwest had pre-carnival Zumba classes up on San Fernando Hill every Sunday that was free, and I mean, they have Queen's Park Savannah, people come out and do aerobics there. Somehow, as Trinidadians, we're most healthy just before carnival. There is a goal there, and it's the costume. But we've done studies. As a country, we are the most motivated and the most healthy just prior to carnival. We're great January, February, March. Don't talk about, and most of us have to work off December, November. Christmas is particularly bad for our diabetics. So the Fight the Fat campaign started off really, really well, and then at some point maybe lost a little momentum. The Know Your Numbers is still being used actively in the health centers, and I think that is your first point of contact. 80% of Trinidadians cannot afford private health care and access the public health care system through the health centers. There are, as you heard before, almost 100 health centers stretched across Trinidad and Tobago. And you have access if you wanted to. Not all of them are fully functional, but pretty much all of them, at least 3 times a week, have a physician present, and every single one of them has a chronic communicable disease clinic, which is always oversubscribed. Now, here's where we get tricky. If I have one doctor, and I've been in a clinic where I have to see 70 patients in 4 hours, the time that I need to properly educate my patients when I need to deal with a diabetic toe and somebody with a stroke and somebody with sugars of 60 and somebody with a blood pressure of 200 on 104, all of which are not good, is very limited. So I think to answer your question directly, the primary point of contact is the primary healthcare physicians in the health centers. I think the nurse educators are where we lack, and that's where we've been trying to, or the ministry's been trying to work out, because the argument is, while we may have only 1 doctor in a health center, we have about 4 nurses, and if one of them can take the mantle of nurse education or peer education, that would help significantly. But the other thing we've learned best is that patients learn from each other, and therefore we've started to get the diabetes camps for children being run out of the pediatric department at Mount Hope, and also the Diabetes Education Center that I know Southwest has and I know Central has, where we get groups of patients to come in, like Alcoholics Anonymous, like Narcotics Anonymous, like all of the patient groups, and they discuss healthcare issues pertinent to them, and those tend to be the most valuable for right now interactions between patients.
There were two questions.
With respect to the nursing educators as well, in the general hospital where I work, we actually have a diabetic counseling department, which is run by nurses. And what they do is that every time we have a diabetic onto our ward, we refer the patient to a diabetic nurse counselor. So they all come up really eager within 10-15 minutes, and they talk with the patient, they take all their contact details, they get the whole family involved, because remember, this is a lifestyle change, not just for you, but it also affects the entire family. So they get the family involved, and even on discharge, you have to go to their sessions. As Stacey said, it's just like Alcoholics Anonymous. They go to the mall together, they go camping together, they spend weekends together, and a lot of patients, you know, when we're not around, they talk with each other. So, you know, they will hear this other one say, okay, I went to this and it worked for me, and, you know, they get encouraged by the other patients who are doing well. So that's what we're doing in the general hospital as well.
There's a question from this lady here. Another MA student, MHA student.
Yes, cohort 7. Now we have mentally ill clients with chronic non-communicable diseases. And I'd like to find out what emphasis is being placed on community mental health in terms of the chronic non-communicable diseases and those clients.
Where do you work?
Mental Health and Wellness Center.
Answer the question, because you know the answer already to that question. Where do you think our emphasis is where mental health, and not just chronic non-communicable, I know where you're coming, so I'm challenging you now. If you have to say to us, where is our emphasis with our mentally ill patients, where any communicable, do we have an emphasis? No.
Well,
okay, I don't know why you're afraid. That's what this is for, yes? So absolutely, and this is not just what we see here in Trinidad. Worldwide, it is an absolute challenge. Mental health is actually, so WHO is great. They've listed 4 chronic non-communicable diseases that everybody's supposed to be focusing on. But there are another 4 that they want to bring on to the 4, which includes mental health, specifically suicide as well. So mental health, dental health, hematological conditions, and y'all will forgive me for getting the 4th one. But anyway, mental health is actually the 5th on the list where they have felt. So right now it looks like they're pouring their efforts into the first 4. But the next 4 are going to rapidly rise because we have acknowledged that not just here, but worldwide, there is a huge deficiency in the overall healthcare of people with mental illnesses. And so I agree with you, our focus has not historically been with the mental health patients. However, I will say that I have seen in San Fernando, I don't have direct interaction yet, a mental health, no, not the liaison, a mental health unit on the hospital compound that has just been established. So things may be looking up because it's a start. It's a start. Oh, I think she needs the microphone.
Next question, please, just the mic.
Yes, good evening to the panel. My name is Virginia Joseph. I attend 2 clinics, the mental health clinic and the Oxford Street clinic, public clinic. And I also have a private doctor. I don't know if you know him. He's Dr. Mansour Ibrahim on Henry Street. Yes, he's my physician for many, many, many years. And I go to him. If I'm not satisfied with government, I go to him. But I have a trace of sugar, I have pressure, I also have mental health problem. And I am 4 months away from my 70th birthday. And I must say I do not have no complaint whatsoever. Whenever I go to the doctor, any complaint, no complaint. And I pray to my God and he keep me safe. I live on a mountain, and when I go to town, I don't have a car. And I go to town, I walk all over town. for my exercise, and then I take a can go home. I cook my own food, and when I cook, everybody around me get food. Everybody around me get a plate of food. And I'm thankful for the Lord for keeping me and making me live to see my 70th birthday.
Is for the 80th and the 90th.
All right, thank you.
All right, I was happy to hear you mention, oh, good evening panel and fellow members of the crowd. I was particularly happy to hear about children, because my question is, what are we doing to address chronic non-communicable diseases among children? We have a rise in childhood obesity, and it is really beginning to get ridiculous when you walk into a primary school and most of the children outweigh you. So what are we doing about our childhood chronic non-communicable diseases?
Two things. 6% of our primary school children are obese. By 2020, 25% of our primary school children, if we continue the way we're doing, will be obese. This study was done in 2011. 11% of those obese children between the ages of 6 and 12 already have something called microalbumin, which is basically protein in their urine. We're in a little trouble. One of our professors from the university shows a picture that's beautiful. A picture with, Eric Williams, back in the 1980s, surrounded by school children. Lovely little bright-faced, cherry, skinny children, bless them. Surrounding this man who is very short and small-statured. And then he fast-forwards 25 years, and he shows a similar picture with the Honorable Patrick Manning, the previous Prime Minister, again surrounded by children. And the difference is amazing, that even from that picture, you can see many, many, many obese children hugging up Mr. Manning. So yes, we have a problem. We have two solutions that have started already. Mount Hope has started an obesity clinic, a pediatric obesity clinic, where children with raised BMI can be referred to, and they are seen and assessed by pediatric endocrinologists, and there is a program there for them. It's just started, it's in its fledgling year, but unfortunately the clinic is already oversubscribed. I don't know if it's that, in any ways, it's started. And the second thing is the diabetes education. The Diabetes Association of Trinidad and Tobago every year runs a 6-week pediatric diabetes camp. And this is an in-house camp. They bring them, you sleep. Some doctors, we all have to take shifts, and the nurses are there, and it's a learning education camp, but it's also a fun camp. So I can identify two very specific things that are being done towards our children. We are also having dietitian targeted lectures through our school feeding program. All of our school feeding program meals are dietitian prescribed. So they're balanced meals. Don't mind that the kids only like the ones that they get on Fridays, which is pizza and hot dog, bless their hearts. But Monday to Thursday, the meals that are prepared for them are dietitian prescribed. So we are trying. We have a long way to go, don't get me wrong, but it's a start. It's a start here.
Dr. Antoine.
Thank you for the, I think everyone can hear me. Physician extenders has been used for many years in many countries. Why are we not using physician extenders here for the basic education processes, blood pressure, hypertension, and those types of things?
You want to define what you mean by physician extenders? What is it?
The nurse practitioner, the physician assistant, who can function independently of a physician. However, they still practice under the guide, per se, under the license of a physician. And I'm sure in emergency medicine there are many physician extenders and nurse practitioners, and they are very skilled. They're, in my world anyway.
Dr. Barrett?
In neurosurgery, they use them also in surgical specialties.
Dr. Barrett? You wanted to talk about the physician extend. This is a very important, you've raised a very, very important topic. which is physician extenders, nurse practitioners, nurse physiologists, anesthesiologists, and so on, that are being used in other places. For example, for a long time, they were using, when I was in Jamaica in I don't want to tell you. When I did my MBBS, up until 1984, they were using nurse practitioners in Jamaica since then. And up to now, we have not been able to get nurse practitioners recognized in Trinidad and Tobago. So, Doctor, would you like to tell us a little bit more about what happens with the physician extenders in your emergency department?
Well, in the case of emergency medicine, we all work as a team because, a patient coming in with a stroke, that's an acute life-threatening diagnosis, and we need to get on them as quickly as possible. So as soon as they come through triage and we know that there's an acute stroke going on, the medical technicians are there putting IVs. The nurses, the PAs can assist in getting.
PAs are physician assistants.
Yes, physician assistants. We don't have nurse practitioners working in the emergency department. The PAs, they essentially act independently of the doctors unless they have a problem or a question for us. And in all honesty, we don't have to oversee their management. And in cases like that, it allows us to be able to see the more acute patients, like the stroke patients, without having to go and see patients who are not as sick, essentially. They are, throughout the United States, they are an integral part of the emergency department. And I believe in the hospital wards also, in the United States. I'm not sure how it is here or why it's not here in Trinidad. I guess you will.
It's not here because of lack of legislation, basically.
Okay.
But right now, over the last 3-4 months especially, I know it's been, because we watch Parliamentary Channel occasionally, I know for sure the Minister of Health is looking at it. It's on the newspaper, it's on the internet, it's something we're looking at now. Nurses as well as midwife assistants.
Dr. St. Louis, Dr. Antoine said he used physician assistants and nurse practitioners.
Yes, in my practice, the use of a physician assistant is paramount. The physician assistant is able to assist with seeing patients, collecting tests and data. I heard you mention a while back how you had a clinic with 70 patients to see in 4 hours, and I thought to myself that I saw something recently that really amazed me, but at the same time made so much sense. And there was a young student that ran around behind an emergency room doctor, and that young student was called a scribe. And I don't know, do you use scribes? Okay, so they are, in the emergency rooms and in those settings, the scribes are absolutely paramount, and in the clinics. Okay, good. Yes, but we do use them in neurosurgery quite a bit. They assist us in surgery, they assist us in the clinics, they assist us evaluation patients and consults, because you're only one person. You can only do so much. You only have so much time, and this now expands your time, because with the skill set that they have, they're able to now make themselves much more utilizable.
Often it is said that sometimes you cannot see the forest because of the trees. Because we are in the health system here, we are not always able to have an objective view of our health system. It's good to have a panel from abroad that can actually look at and give us insight and helpful suggestions to improving our health care. The other thing I want to mention is these guys are truly Trinidadians. Not one of them has an American accent. And that's good, because 2 of them left, one left at 7 and one left at 11. Isn't that wonderful? Is there another question, please? Let's have this gentleman, please.
Okay, good afternoon, everyone. My name is Corey Dillon. I'm a registered mental nurse. I have one question and one suggestion / question. Firstly, Trinidad signed on to Caribbean Charter for Health Promotion in 1996, which had certain pillars that they were supposed to channel healthcare services in those directions. I would like to know if anything is happening in regards to that. And secondly, I just want to go back a bit to the childhood obesity. Now, at present, over 98% of people will pass through the school system. If we want to have some type of education system in terms of promoting health, why not infuse it in the education system so that every single child must know of it? I don't know if you all have any plans of something like that, whether it be a subject or what, in the school curriculum for health promotion. Thank you.
So not only in 1996 did we sign a charter, but in Chogam in 2011 we signed the charter. In 2010 we signed the charter. And in 2013 we signed a Commonwealth Medical Association charter with visions for health, all of which mimicked the 1996 vision and steps for health. It's not that we don't know, it's not that we don't know what the problems are. And we're not the only ones. Jamaica has the same problems, Barbados, St. Lucia, Dominica. When the Commonwealth countries come together and talk, all of us, big or small, Nairobi, Kenya, Sri Lanka, Philippines, all the developing worlds, when we come together and talk, we identify the same barriers. And education is a huge one. I'm going to speak tongue-in-cheek and say that some of our patients will quicker go to a herbalist or a naturalist, and you all know this, and will, even though I diligently give you your hypertensive medication for free on CDAP, you have it packed up and then they bring back the medications in the high-low bags, tons of it. Doc, I ain't taking these, you know, because I went and I'd taken this bush, which is fine if it's helping your pressure. So the challenges and the visions that they have for helping the health sector, and there are charters upon charters that are being signed, and unfortunately, we are still working, and we will continue to work. And the system has come a long way. Back when I was a medical student, we are not going to say how far along that was, compared to what I see now, we have come a long way. I think anybody who works in the public sector now can see that there have been changes, mostly good. Some not so good. There's too much paperwork now, I think, but mostly good. So we're getting there. The second part of your question, you're right. We have to get into the schools. Health education needs to be a part of our school curriculum, our primary school curriculum, and that recommendation has been made through the Ministry of Education.
Right. I think the Ministry of Health initiative, the STEPS program, is a start towards these charters, because it's using the WHO's their mechanism, so it's a stepwise approach. So what the Ministry of Health did is that the survey I mentioned before, the STEPS survey, is looking at the risk factors and the prevalence of these risk factors in Trinidad and Tobago. So we've already completed that step. So now we're moving on to the next step, which is we're looking at like blood results, we're looking at the levels, like taking blood tests and actually checking the levels of HDLs, which are good cholesterol, LDLs, your bad cholesterol, like looking at the figures. So far we've done the first step, we found out the risk factors, we found out the prevalence of the risk factors in Trinidad and Tobago. Now we're moving forward, because now we know what to target, because my prevention is better than cure.
Good afternoon, Alison Pouchet of Cohort 6 MHA program. Today we were speaking about health and wellness in the primary health care, and our contributions here as a panel today for improvements in our health system in Trinidad and Tobago. First, I think we have to ask ourselves then, who are our customers? What I come up with all the time is the customers who we see are ill people. Secondly, what do? We treat ill people. What should be our plan then? Shouldn't we be then looking to be a wellness center? This is what this afternoon is about, getting our primary health care to wellness. Therefore, we have to get a plan. And we all said it, Dr. Barrett, you said about Diana, about the MGs, and the Ministry of Health goals and the national goals. And so we need to align our planning, because all what you all are saying is true and it is going on, and we know they're going on. A particular of interest is this: every professional is doing their best, operating in silos. We do not have standardizations of care really seriously taking place, and team effort. I heard the doctor said about team. We need to seriously focus on a good team, having that customer wellness at hand. We are the Ministry of Health, and we should be seen about health and de-emphasizing. So the primary health care is not just about that patient, what they present there, but all the other determinants, all the other social aspects that they are faced with, the children eating. Why are we not stopping the sale of snacks around schools or even in the school, you know? So things like that, basically. So we looked at patients, the responsiveness of our health sector, how do we respond to really what are the needs? We look at what the patients say. We have gone out there, some of our students, we have gone out there and actually spoken with patients in renal clinics and diabetic clinics, and we are hearing they're confused. First of all, we are not standardizing our care. A nurse tells them something, they treat the wound something somewhere up so, and then the other person says something, they're confused. So we need to address that primarily, standardized care. And we also need to hear what else do they need. Advocacy groups, I heard somebody else say, let the patients get together and talk together and come with what they want us to provide for them.
Well, first of all, I want to thank you for your contribution. It wasn't a question.
No, it wasn't.
And that was good, because this is not just a question and answer topic. This is really an open panel discussion. That's the first point I want to make. The second point I want to make, except for the lady who lives at the top of a mountain, to the best of my recollection, nobody of the general public has said anything. And we need your contribution as well. If you are one of the members of the general public, if you have a question or if you have a suggestion, the last person who contributed talked about listening to our customers. And this is one forum that we're encouraging that. We want to listen to you. So if you are a member of the general public, you have a suggestion to make, please, we want to hear you. Professor Narayan, question please, or comment, or suggestion.
My contribution is a comment followed by a question. First of all, I must commend the level of questions asked this afternoon. I'm really very happy about the questions. And my own is a sort of a follow-up to the last two questions. First of all, a comment. I consider primary health care as analogous to preschool education and primary school education. If we get it right there, we have no problem at the secondary and tertiary level. Similarly, with the primary health care, if you want to have a productive nation, etc. But I noticed a lot of the discussions were focused on the patient who is ill and the systems we have in place addressing that. I feel that we should prevent the people from getting ill. And the question I'm putting here, whilst you focus on that, and since we want to target the young people, because that's where we have to, if we're going to find a solution, and I didn't hear during the discussion, that is a question, to what extent are we using the technology, today's technology, in addressing the problem of primary health care? And you know the first person that a young child meets in the morning, it's my quotation, is the gospel according to Google. That's what they meet, isn't that so?
Correct, yes.
And therefore, what we should have been doing, I'm making the question, to what extent in your strategic planning, finding solutions to problems, have we made use of Facebook, YouTube, the cell phone, etc.? And to me, that is critical, because that is the lifestyle of our young people. So yes, we go and we have these establishing clinics across the country. It costs money. Then we go and we talk about these. Once a month you hear the PA systems around the villages. We're going to have this health fair in the community center, etc. Yes, these are important. But to me, again, as a suggestion, have you all thought about using this strategy? This is what the young people know about, nothing else. Isn't that so? Yes. And we should be using the media that they are doing. And I want to now make a plug for UTT, because just last week we launched something which is, to me, going to be transformative in this nation, and that's called Knowledge TT. You probably haven't heard of that, right? It was launched last week. Coursera and all of these people on it. And therefore, we can now use this sort of information that you want to get to the public using that platform of Knowledge TT. It's on your cell phone, on the internet, in the government channel, right, etc. It's there. If you're in a bus stop, you can be looking at your cell phone and you're getting the information. And I feel that we have to use the technology that people are accustomed to, the young people, to bring this message across. Otherwise, I think we'd be spinning top in mud, the effectiveness of it and the cost of the thing. And just to give you an example of what I saw in the technology, not in primary health care. They use the technology from the drone. You know the drones, right? The unmanned aircrafts by the US. The sensors, and the doctors in New York, they implanted the sensors into the patient, right? Which cost about $350 at that point in time. This is just a couple of weeks ago. And what is happening wherever that person is around, one doctor on the screen was monitoring thousands of patients. That's why we're using the technology. And therefore, you're reducing the cost. And what happened in that case, it's really, I must say it, right? There was this guy who had hypertension, right, and also diabetic, in one of the streets of New York. And suddenly, an ambulance pulls up along him. And he told the guy, come into the ambulance. The guy looked amazed. I didn't call an ambulance. He said, yes, we have been monitoring you from a central command station. We recognize that your blood pressure is at a critical level, into the ambulance, straight to the hospital. And this is just, I want to say that what we should be doing, therefore, is a comment really. To what extent have you in your strategic planning making use of technology, which is everything?
Before the panel answers that, I've jokingly said that we have a new generation of people who have Parkinson's disease. They must have Parkinson's disease. And they're trying to mask this Parkinson's disease by something in their hand. They don't want anybody to know that they've got Parkinson's disease. So what Dr. Dyer says is absolutely true. And to add to him, there was a study in, I think it was in India, where they had monitored sex workers using the cell phone coming into a central station. And they were able to find out over a very wide area where they didn't have any doctors and so on, they were able to track what was going on. So this is a tidal wave, one particular philosopher or writer, manager, management chief talked about shock waves and tsunamis. And he said that whenever people recognize a tsunami, they either ride it or they get destroyed. So we have to look into the environment and see what are the major changes taking place. And as health workers, we've got to ride that. Because if we ride that tsunami, and in this case, the tsunami is the technology revolution. So over to the panel.
Again, technology, I believe, is something that is inevitable. In the operating rooms that I operate in now, it's primarily computer-driven. It's all image-guided. It's all lasers. It's intraoperative CT scans, intraoperative MRI scans, and this is all merged with computers and guidance. Gone is the day where you don't know where a brain tumor is. This is the day now where you can take a brain tumor out and while the patient is still asleep, put them back in the machine, check the tumor and make sure that it's completely out. And if it's not, go back in and map it and whatever have you. This is a day when in the emergency rooms, the neurologist who's the specialist who's interviewing a patient isn't even in the emergency room. He could be anywhere in the world. Telemedicine is very much the way to go. And this is critical when you have such conditions as an acute stroke that you mentioned earlier, because we know that we have to give patients that TPA to try to, the clot busters, and to do that, you can't wait for the neurologist to come to the hospital, so they pull the monitor in and they set everything up, and the neurologist stays wherever he is, in his office, in his home, in his, wherever he is, and he interviews the patient, makes a diagnosis, and immediately the patient is taken and has the TPA provided to him. So telemedicine is on the way. Recently, I read an article about the Google Glass. That's a new one. And the Google Glass is a device which is a pair of glasses. And this pair of glasses incorporates cameras, monitors for the individual to see, microphones, and integrated into it is a chip that allows you to have a program as far as patient care, best care practices, whatever have you. It integrates with the patient's chart, integrates with the patient that you're seeing, the interview, it collects the data. It is just phenomenal. Now, all of these things we kind of look at, and it's like the Jetsons program or the, you know, the cartoons we used to look at when we were kids and thought that they were really just futuristic. And all of this is going to happen. It's inevitable. Now, how quickly Trinidad and Tobago and the community, the medical community that's here, is able to incorporate the things that are going to work, not all the superfluous things, the things that are going to work, the things that are going to be to benefit us, the things that are going to make a difference. I think that is the critical piece. And from my standpoint, at some point, we need to talk about the emergency services and how those are going to be. I mean, the traffic here is unbelievable. You can't, I don't care what you say, an ambulance cannot get a good facility within great times. They do? Oh, yeah, right. I mean, so we can talk about some of those things later on, but thank you, go ahead.
Can I just, as a point of interest, ask, how many people in the audience own a bath scale? Okay, how many people in the audience own a cell phone? Everybody raise your hand. How many of you who own more than one? You could raise both hands now.
How many of you the bath scale works?
And doesn't have dust on it. Right. I'm very curious because I always ask people that. They have two cell phones, but they're hypertensive, but don't buy a blood pressure machine, but they have two cell phones. So whereas I take your point, Professor Reinsing, and I absolutely agree, because we are now, I'm getting people WhatsApping me pictures of skin rashes and x-rays and their blood results, and that gets scary because there's a whole ethical domain. I'm sitting in the middle of a dinner meeting and I have a child's private parts. Doctor, child have a rash, what to do? You know, and there's no privacy, but so it's happening already. Our patients are doing it for us, and it makes life easy because I can say, go to the closest emergency room, I don't like the look of that, or no, it could keep till tomorrow, do so. But I think we have to be very realistic, sir. I agree we have to use the technology to teach to prevent. I agree with that. But I think as doctors and as educators, it's only so, I mean, I have so much knowledge about computers, and I get Facebook and WhatsApp. Sure, ask me how much time I have to spend doing this, because your life is busy. So I think we have to be very realistic as to how we use the technology, because there's a lot of information out there that's not correct, that patients use in the wrong manner and get panicked about. And then you do a lot of troubleshooting and a lot of damage control after the fact. So it's a two-edged sword, sir.
Yes, but that is from the patient's point of view.
Yes.
But we, as a health system, have to look at it from the administrative point of view and from planning to what we are going to do in the future. I work at the Eastern Regional Health Authority. That means our hospital in San Grande covers Matlot to Guayaguayare. There is no way that a stroke patient in Matlot or in Guayaguayare could ever reach San Grande Hospital in time for effective treatment. It's an absolute imperative that we use telemedicine in such a far-flung area. And it's available because I can sit in my house and I could look at the x-rays that of my patients taken in Medical Associates in St. Joseph. All I need to do, all I need is a web browser. And I log in and they can show me the x-rays and I could tell them what to do. So it is happening in the private sector. It is not happening in the public sector. We need to have a paradigm shift and bring telemedicine to the fore in Trinidad and Tobago.
Excuse, I want to get one suggestion. Yes, ma'am. And they talk about the children, but what about the senior citizens who is well and strong?
Yeah.
I just clean my house, I just make my grocery, I just cook my food, I just fill up my water, I just get somebody to clean my yard. I make only thing.
Not easy.
And if you look sharp, I just take my cutlass and take the rest.
We're going to ask you, we might think of asking you to be a lecturer at some of the health centers.
From the Ministry of Health here, all you fix up what you know.
Yeah, I just, before they get ill, let them be around and do their work and things, and I could see them first and in good condition.
Dr. Connie, if you want to say something? Can I have your question, please? Or suggestion or comment?
It's really scary, I should say, the age of the persons that we are seeing coming for treatment at the National Radiotherapy Center. I have a question and a comment, and it is geared towards primary health care and the inadequacies because especially cervical cancer is on the rise. And in the absence of national screening or the statistics collecting agency, which is Cancer Registry, their statistic is dated back to 2007. So Trinidad and Tobago at present really does not know the true cancer statistic that we have in Trinidad. So that's just a comment. And stemming off from that, standardized education. I'm a recent student at the School of Advancements in Education, and we went to the Royal Mountain Hospital for our practicum last year. And what was really amazing, we must start to build a strong foundation in terms of education and awareness. And at present in Trinidad and Tobago, that is totally absent. There's a system called the Patient Education and Liaison Service, which is standardized patient care and patient awareness. And unless we start there, we are absolutely doing nothing for our patients here. If you go to Google, and one of the things that's crippling and killing our patients in Trinidad is misinformation. And with information comes fear. And you know, they usually we see patients in the health facility when water more than flour. And what is really alarming, especially the younger persons that we are seeing at NRC accessing cervical cancer treatment. And for me as a young person, that is really troubling. And I'm sending all direction now in terms of my next question. When did our primary healthcare system become a treatment facility for maternal and child care? Because there's no preventative information being disseminated. There's no place you can go for information in terms of up-to-date information. Cancer, you see those spurts of things when they're National Diabetes Awareness or World This Day or World That Day. But in terms of consistency, it's absent. And as I've been in the health system for a good number of years, and I think I stand on common ground with a lot of the colleagues and persons who might say that we could no longer continue to do this willy-nilly. Because when we do have this tsunami, it's not just the diabetes, we are going to get the more expensive illnesses such as cancer. So when did we move from that in primary health care? There's no one you can go and speak to. The health center, so when you're sick. Maternal and child care, prenatal, postnatal, that is it. So we are doing something seriously wrong when we are missing these areas. one of the things I appreciated traveling is that everyone in a particular area geographically must be registered with the community. Like our health center, you must be registered. And they follow you throughout your growth and development. Because as we get older, our changes in terms of what we need health-wise will change with us. And there is where the community follows you. So you will get your urine tests and all these different swabs in the mail when you reach these developmental milestones. So please, could we, as a panel, as an organization, see how we can help our young people and stop helping us sick Trinidad and Tobago get sick.
Now, we're going to have to end in about 3 minutes. So, quick questions down in the back, please. If you can make your comments brief and to the point. Oh, that is...
Fagurala.
Yes.
Yeah. I work with Eastern Regional Health Authority as one of the physicians in the primary health care. Just two things I would say briefly. One is that the lady had mentioned about education. What I know is that, and it's quite close to me, is that we have health education departments in the administrative arms of Eastern Regional Health Authority, that I know for sure in STAD and in Naiva Mayaro. And I also know that they meet regularly with the Health Education Department in the Ministry of Health as well. So maybe there's some improvement, that needs to be done. But to say that there is no place, where you could seek information, in Trinidad and Tobago, I would not totally agree to that. My second statement is that Professor talked about IT and the need to revolutionize the health system. But one thing that keeps ringing in my head is that how do we finance our health system in Trinidad and Tobago? There are times that we've tried insurance, and there are private insurance that people take up, so that what is the government doing? And I know we have some panel members here that are from America, and I know insurance and health insurance, it's a great thing there. So what in Trinidad and Tobago, what are the the avenues that we're looking at to implement our health system, so that we have a way of financing the institution?
That's a whole different topic, which we don't have time at this time to talk about, I'm afraid. So, can I have your question, please? And that's the last question.
In your practice, and especially for patients who have had disability problems with respect to mobility, in your practice, do you find that patients where the cost of a mobility aid, such as a wheelchair and a walker, versus the benefits? And what do you think the role of a mobility aid is in the rehabilitation of a patient, a stroke patient?
Okay, at the National Rehab Hospital, excuse me, our patients have insurance, and if the insurance will not pay for the wheelchair or the walker, we do have a patient care assisted funds, which the employees contribute to that fund every pay period, if it's $10 or $15, and that money goes towards equipment that the patient cannot afford to buy. Does that answer your question?
Well, I in Trinidad, we don't have that. We just have a disability grant. So that is a good comparison to see what's available abroad and what's available here. But my question is also, what do you think is the role of a mobility aid in the rehab of such patients?
With our stroke patient, As you heard in the conference today, when a patient has a stroke, we get them rehab as soon as possible. The earlier is the better outcome. So they may be in the acute care hospital maybe for 2 days, and on the third day they come to national rehab. They have 3 hours of therapy every day. If the patient cannot tolerate 3 hours of therapy every day, they're sent to another acute care facility until they could tolerate 3 hours of rehab therapy.
Okay. So acute care physical therapy, and then when they can manage, they transfer to mobility aid then?
Yes.
They do? Okay.
And then they come back to us when they could tolerate that therapy. 3 hours.
Okay, thank you.
Okay.
Ladies and gentlemen, this discussion is really waxing warm. But we have to go because our time is up. I want to, first of all, thank the UTT, the Masters of Health program, for hosting this very interesting and enlightening panel discussion. I want to thank the Caribbean medical providers, practitioners practicing abroad. I don't know how long has this been in existence, Dr. Antoine?
In my head for about 20 years.
And
in reality, in this form, 1 year.
1 year.
This is the first time we've ever done it.
So are you planning to come back next year?
We're going to Tobago next year. That has a nice flow to Tobago.
Right.
And we'll do.
So we're looking forward to a similar panel discussion next year.
Absolutely.
Good. So we'd like to thank Caribbean medical providers practicing abroad for this session. We also want to thank our very esteemed panel. We hope that they enjoy the rest of the stay in Trinidad and Tobago, and we look forward to seeing you all again. Thanks, but most of all, we want to thank the members of the public who came. Because unless we can get members of the public involved in healthcare, we don't really know what our customers think. And the suggestions that you have given are very, very valuable. Thank you all for coming. We hope you reach home safely.
Thank you. I would just like to make one comment. Tomorrow, we, CMPPA will be hosting a slew, I would say, of doctors. It's just a basic medical conference where doctors speak on the topic of stroke tomorrow at the Hyatt Regency, Trinidad. So we'll start at 8 in the morning and we'll go all day and do just lectures. But on Sunday, which is important to the community here, what we'll do is go out in the community, in 3 communities. We're going to go to Arima. I'm from Arima. And I'm from the Kenton Street, Temple Street area, the best part of Trinidad, right? If you know it. All right, so we're going to Arima Boys RRC School, right? And we'll be there around 8:30, and we're going to just be doing blood pressure, hypertension, and cholesterol screening. If you want to volunteer, if you want to come out, if you want to bring your grandma, your grandfather, your uncle, or your aunt, if you're from that, if you have someone there, please bring them out. We're also going to Chaguanas, and we're going to the say again? Chaguanas Revival Time Center on the corner of Darling Street, right? And Pastor Ramdas, right? He's a big, beautiful church. We come out and volunteer with us. Just come out and help, or you just bring your aunt or uncle if you have someone living there. And the next place we're going to in Mova is the new Mova Primary School, and that's on Coconut Drive. And we'll be there around 9 o'clock in the morning. So if you want to come out and help, please do. And thank you guys for having us.
So thank you all. We look forward to the future for similar panel discussions. We wish you a safe journey home.